Hello, and welcome to the Tips and Tools to Calculate Appropriateness of Cardiac Radionuclide Imaging webcast. I'm Mary Beth Farrell, the IAC Director of Accreditation for Nuclear and PET. During this webcast, I will be explaining several tools currently available to help facilities measure appropriate use. There are two other webcasts in this series providing more detailed information on the subject. The first webcast describes the appropriate use criteria, explaining how to use them, and some of the terms and concepts that may be unfamiliar to nuclear medicine technologists. The second webcast explains the IAC Nuclear PET accreditation requirements for incorporating appropriate use criteria into clinical practice. Both of these webcasts may be found on our website under the Sample Documents section. During this webcast, I'll describe the four methods or tools available to help facilities calculate the appropriateness of a clinical indication. They include the algorithm spreadsheet method, the Astellas App, the Skyscape app, and finally, the ACC Focus Tool. I'll also be demonstrating how to use all of these tools. The tools that are available to help facilities determine and measure appropriate use are all fairly easy to use and free. Depending on the method, some of the tools simply calculate appropriateness of a clinical indication, while other tools calculate the appropriateness as well as calculate, analyze, and track the percentage of appropriate, inappropriate, and uncertain indications. All of the methods or tools are based on the American College of Cardiology Foundation 2009 Appropriate Use Criteria for Cardiac Radionuclide Imaging, which can be downloaded from the American Society of Nuclear Cardiology website at www.asnc.org. I'd like to point out that this document explains in detail how to determine appropriateness of a study without using special tools or apps. There is also a recently published continuing education article in the June 2012 Journal of Nuclear Medicine Technology. And to be truthful, I'm the lead author, and I wrote the article specifically for technologists to make the appropriate use criteria easier to understand. So let me explain how to use the criteria. The 2009 criteria are sorted into 8 tables. The indications are categorized based on the detection of coronary artery disease in symptomatic patients, detection of coronary artery disease in asymptomatic patients, risk assessment, assessment of viability, and evaluation of ventricular function. These logical groups of similar indications make it easy to apply the criteria to real patient scenarios. To facilitate use of the criteria, a hierarchy of potential test ordering was created. An algorithm points users to the correct table based on the patient's clinical presentation. Appropriateness of the indication can easily be determined by answering yes or no to the following 6 simple questions, going to the applicable table, and then selecting indication based on the patient's pertinent medical condition. The first question in the algorithm is whether or not the patient is being studied as part of a preoperative assessment. The appropriateness determination for preoperative imaging follows the ACC AHA 2007 perioperative guidelines. If the patient is being studied for preoperative assessment, the indications in Table 4 are applicable. Surgical risk, clinical risk factors, functional capacity, and patient symptoms are also considered in further narrowing down the correct indication. If the patient is not for preoperative assessment, the next question to be answered is whether the patient is within 3 months of an acute coronary syndrome. If the patient is within 3 months of acute coronary syndrome, Table 5 is considered along with the patient's symptoms and whether the patient had a prior coronary angiogram are used to determine the indication. If the patient is not within 3 months of an acute coronary syndrome but is being evaluated after percutaneous coronary intervention or coronary artery bypass graft surgery, clinical indication is determined by evaluating Table 6. The patient's symptoms, success of revascularization, and the time of the last test are used to determine the indication. The next question to be considered is whether or not the patient has undergone prior testing, such as an exercise stress testing, echocardiography, myocardial perfusion imaging, coronary angiogram, or coronary calcium score. The type of prior testing, length of time since testing, and whether the patient is symptomatic are considered in Table 3. The criteria suggests that it is inappropriate to repeat stress imaging within 2 years unless the patient has new or worsening symptoms. The final questions in the algorithm relate to whether the patient has symptoms. If a patient has an ischemic equivalent, then Table 1 is used to determine appropriateness. Key in the evaluation of symptomatic patients is the patient's pretest probability of coronary artery disease, ability to exercise, and ECG interpretability. If the patient is asymptomatic, Table 2 is used. In order to determine appropriateness in an asymptomatic patient, the patient's coronary heart disease risk using the Framingham risk score and interpretability of the ECG must be considered. In addition, other factors such as if the patient has heart failure, syncope, atrial fibrillation, or ventricular tachycardia are important, and radionuclide imaging may be justified. A more detailed explanation of how to use the algorithm and definition of the associated terms is included in the Appropriate Use Criteria Explained webcast. Here is an example of one of the 8 tables included in the appropriateness document. This is the table for detection of coronary artery disease, risk assessment in patients without ischemic equivalent, or in other words, without chest pain. IAC-accredited nuclear and PET facilities are required to measure appropriateness at least once during the accreditation period in consecutive patients equal to 5% of the annual volume of patients imaged in the facility. Therefore, once appropriateness of the clinical indication has been determined using the documents and tables I just described, facilities must track and calculate the total percentage of appropriate, inappropriate, and uncertain indications. This is most simply accomplished by using a spreadsheet. A sample Excel spreadsheet is available on our website. The spreadsheet documents the patient identifier, date of the study, ordering physician, whether the study was appropriate or not, and then the actual criteria or indication. The spreadsheet also calculates the overall appropriate, uncertain, and inappropriate indications. After collecting this data, the facility can then drill down into the data, investigating all of the inappropriate studies, looking for patterns or similarities, and then trying to find ways to improve. You can download a copy of this spreadsheet at www.intersocietal.org/nuclear in the Sample Documents section. Let's now move on to discuss the Astellas tool. Astellas Pharma released a free application, or app, in the fall of 2010 to help guide facilities through the process of determining whether cardiac radionuclide imaging is appropriate. The application is currently available for the iPhone, Android, and BlackBerry. The Astellas application can be accessed at www.astellasapps.com. The Astellas program follows the same algorithm I just discussed to direct labs to the appropriateness of an indication. A nice feature offered by the Astellas is an online desktop version for people who don't have a smartphone. Also on the website, there are free recorded webcasts about the appropriateness criteria by leading experts on the subject. The online version works exactly like the app and the algorithm. So let's try an example. Let's say a 79-year-old woman is referred to your office for a myocardial perfusion test. She states that she walks a mile twice a week and does not have chest pain or other symptoms when walking. Her ECG is normal, but she does have several known cardiac risk factors such as hypertension, elevated LDL cholesterol, and she smokes. Giving you a hint here, this means that she has high coronary heart disease risk. She has not had other cardiac diagnostic testing. So let's use the Astellas app to determine if the study is appropriate or not. So to begin with, is this patient pre-op? No. Is she within 3 months of an acute coronary syndrome? Has she had prior coronary angiography? Nope. Has she had prior angioplasty or bypass surgery? Again, no. Has she had prior imaging? No. Does she have chest pain or other ischemic equivalent? Nope. And let me help you cheat here and tell you that she has high coronary heart disease risk based on her Framingham score. To learn more about this, please refer to the appropriate use criteria explained webcast I mentioned previously. So after working through the algorithm, we can determine that this study is appropriate. By using the Astellas app, we can quickly and easily determine whether the study is appropriate or not. The next step is to then record and document the findings in a spreadsheet to determine the overall levels for a facility. Let's now move on to briefly discuss the Skyscape app. Skyscape, Inc., a company specializing in mobile medical information, has a tool available based on the 2005 criteria, but they are in the process of developing a new tool to calculate appropriate use based on the 2009 version of the guideline. The new tool, expected to be available on its website soon. The website can be accessed at www.skyscape.com. The last tool I want to discuss is the ACC Focus Tool. This tool is the most robust tool, and it was created by the American College of Cardiology. It is part of their Formation of Optimal Cardiovascular Utilization Strategies, or FOCUS, innovation community. Located within the Performance Improvement module is a program that calculates and tracks appropriate use. Note, ACC membership is not required to access the program, but facilities are required to register to use their website. Our website has a page discussing the FOCUS community and a longer webinar detailing the application. The FOCUS community can be accessed at www.cardiosource.org/focus. The tool specific to nuclear cardiology is the Imaging and Focus Radionuclide Imaging, or RNI, Improvement Tool. It's found under the Get the RNI Tool link. On the RNI Improvement Tool webpage, the link to access the tool is a little bit buried at the bottom of the page. You'll need to click on the Click Here link. Once you enter the program, you may add patients by clicking on the Add Patient button. I caution you not to click on the Submit Data button until you've entered the required number of patients, as this results in your data being analyzed, and you cannot go back and add more patients once you click on the Submit Data button. The FOCUS program is based on the same hierarchy of ordering as I've previously discussed. You begin by choosing one of 6 primary clinical reasons for test ordering. Then by answering the 3 to 6 additional questions, appropriateness is determined. An additional helpful feature of the FOCUS program is that there are links to tables and definitions within the program. For example, if you're not sure of the pretest probability and you want to look it up, by clicking on the link, all the necessary information is readily displayed. So let's use a case example to demonstrate how to use the FOCUS program. For this example, the patient is a 70-year-old male who had a successful angioplasty approximately 20 months ago. Prior to the angioplasty, the patient had chest pain, but since the angioplasty, the patient has not had any recurring symptoms. The patient also has hypertension, elevated cholesterol, diabetes, and smokes. Using the FOCUS program, the first question to be asked is, what is the primary clinical reason for the test order? Our patient had a previous percutaneous intervention or angioplasty. Note, the program also asks a qualifier question here of whether the patient is being evaluated prior to cardiac rehabilitation. This question is primarily used to exit the algorithm and direct to a different table. The next question is whether or not the patient is symptomatic. The patient in our example is currently asymptomatic. The next question is whether or not the revascularization was complete. We know our patient underwent successful angioplasty. The program then asks you to indicate if the patient had a prior percutaneous intervention or coronary artery bypass surgery. The final question asks for the time since the percutaneous intervention. Was the procedure more than 2 years ago or less than 2 years ago? Our patient's procedure was 20 months ago and therefore less than 2 years. So as you can see, by simply answering 6 questions, appropriateness of the indication can be determined. In our example, the myocardial perfusion imaging study would be inappropriate. One of the additional features of the FOCUS program is that once you have entered the required number of patients, by clicking on Submit Data, the overall results are analyzed. So when you're finished and you're sure that you're finished, it's then okay to click on the Submit Data button. This, in my opinion, is the true benefit or one of the most helpful features of the Focus program. The results are analyzed and the percentage of appropriate, uncertain, and inappropriate indications are calculated. In addition, each inappropriate indication is further evaluated and the percentage calculated. The results for a physician are compared to other physicians within his or her specialty and to others within the same practice. The Focus program also contains a performance improvement module that allows physicians to obtain maintenance of certification or MOC points by participating in learning programs and an interactive community. So in summary, I've discussed the 4 methods or tools available to help you calculate the appropriateness of a study. We reviewed the algorithm spreadsheet method, the Astellas App, the Skyscape app, and finally the ACC Focus Tool. Hopefully, the examples I've shown you demonstrated how easy it really is to calculate appropriateness of a study, and you're now ready to try it on your own. The IAC strives to assist facilities in making the accreditation process as simple as possible. A series of other webcasts, articles, checklists, and sample documents are posted on the IAC Nuclear Pet website in order to provide additional guidance to those seeking accreditation. Please feel free to contact me or any of the other IAC Nuclear Pet staff at any time with questions. We look forward to helping you.